I'm Dr. Lily Han. I'm one of the Cook Children's Physician Network providers, and I am also an obesity medicine specialist. I am excited to be a part of our new Prosper Cook Children's Adolescent Bariatric program, and I'll be serving as the obesity medical director of the program.
Hi, I am Dr. Kanika Bowen-Jallow. I am a board-certified pediatric surgeon. I'm also the medical director of the bariatric program and also the medical director of surgical services at Prosper at Cook Children's. So the reality of the situation is that adolescents are already suffering from all of those comorbidities. We know that adolescents that suffer from obesity become adults that suffer from obesity. We also know that adolescents that suffer from obesity are 2 times more likely to die prematurely than their non-obese counterparts before the age of 55. So the outlook is not good. You know, when we talk about diseases, we don't withhold any other treatment for any other disease. For example, if a patient has hypertension, we don't withhold hypertensive meds if they're not living the lifestyle we think they should. If a patient has diabetes, we do not withhold their insulin just because they're not doing all the things that they could be doing to make things better. So why, when we're dealing with the disease of obesity, would we not give these kids the opportunity for something that's safe, effective, and we know through studies lasts long-term in the treatment of their obesity? Right now, the CDC states that obesity is the leading cause of preventable death in the United States, other than smoking. So we have a problem and we need to be able to solve that problem.
Genetics play a very prominent role in childhood obesity. Genetics probably accounts for 40 to 70% of the obesity. Maybe 30% is probably environmental, and the remaining may be psychological factors. And that we have identified many different genes that code for obesity. Sometimes it is a monogenetic obesity. It's just one chromosomal aberration. Sometimes it's polygenetic. It's multiple mutations that act together to create a profile of obesity. So that is important to note. Now, just because you inherit the genetics of obesity, it does not mean that you are destined to be obese. We actually have some control with regards to what genes are expressed, and that's where our environment can be very important. So, but it is important when we talk to our families and patients to let them know we're not playing the blame game. There is a genetic reason that their body has a desired set point or a desired weight that it wants to be. And our goal with treating obesity is to maybe change that set point with what we can do and work together to just have our children reach and become healthy young adults, ideally without obesity. And back to genetics, how genetics play a part into obesity often has to do with where we have our set with regards to hunger, where our hunger levels are set, what type of cravings a person has can be attributed to genetics, what it takes for them to feel full or have satiety, and then also their energy metabolism, or basically when people are burning calories, a lot of that is hardwired by your genetic code.
And just to add on to what Dr. Han was saying, you can't outrun your genetics. And so even in my instance, I have high cholesterol. I do my diet, I do my exercise, it's going to hit eventually. And so I think it's very important that we let families and patients and physicians know there's such a heavy part of genetics that's involved in this, that no matter what you do, it is what it is. And so we should all have the tools to be successful in life and lead a long, healthy life.
We currently have a very obesogenic environment. So there are many factors that play into that increasing, alarming rate of obesity and morbid obesity. So basically, Our diet has changed quite a bit over the decades. We have a lot of ultra-processed foods and we have a lot of media. So those two together work very well together to encourage this epidemic of obesity. We know that ultra-processed foods can cause inflammation in the body. You look at an ultra-processed food, bag of Doritos, Oreos, you turn that label over, you probably cannot pronounce about 75% of those ingredients. So our body doesn't recognize some of those ingredients too. And as we digest those foods, it can create an inflammatory state, even a stressful state for our body. These foods are high in sugar, they're high in fat content, and we know that our body, our hypothalamus, responds to that. We release dopamine and we actually feel joy when we eat these foods, as we've all experienced before. And there is some thought that there could be some addictive potential with this. These are the same pathways in our brain that we see that are activated with alcohol use and drug abuse. So we happen to have some foods that do maybe have some addictive potential, which makes us crave them and eat more of them. And then we have marketing, we have media, and we have media on many different platforms. And actually the most vulnerable age when we look at studies for media would be our elementary school, our younger population. They look at media, they see an advertisement, and they're most likely to just perceive that as the fact and the truth. So we do have studies that demonstrate that the marketing works for our young children. And when they see these foods advertised, this is what they ask for. We note on studies that it increases the amount of food that they intake and also that desire. They're asking their parents for these foods, and we all want to make our kids happy. So we do have a diet right now with a lot of fast food and with a lot of processed foods, which creates an increase in basically caloric intake. And then we have other factors. We're a little bit more sedentary probably than we were before. I know when I was growing up, we had PE every day. When my kids are growing up recently, and I asked the kids in the office, and PE is like maybe twice or 3 times a week. It's definitely not every day in most schools. And then even recess, maybe it's only once a day. It used to be twice a day. And especially in Texas, we don't do a lot of walking. It's really hot. So we all often have a very sedentary lifestyle. And then with COVID, our pandemic, some studies say that might have increased even more rapidly this obesity epidemic that we're seeing. So there's a lot of different factors that come into play. So then, what can we do? What can we do? We need to educate our families and make them aware of the differences that we can make in our own home environment. Talk about nutrition, eat together as a family, stay active together as a family. All those things can help. Some of the other environmental factors that I didn't mention are things that we are working on as a community. Everybody looks at BPA, and all of a sudden, all these bottles are BPA and they're advertised as BPA free. Well, we do have some endocrine interrupters in some of the plastics and different things we've created in our environment, and our body does not know what to do with that. And we are finding that some of those chemicals can also increase our risk for obesity. We also know that sleep deprivation is an issue. When we monitor and we study people with regards to sleep deprivation, we know that it affects their hormones. When you are sleep deprived, you actually make a lot more ghrelin, and ghrelin is a hormone that makes us feel hungry. You make a lot less leptin. Leptin is a hormone that makes us feel full. So it's the perfect storm that when we're sleep deprived or we're up late, that we feel hungry and we eat more. And that does also affect, of course, your body's set point. And finally, one major contributing factor is probably screen time. We have now had screen time around. It's a fact of life. We need it to work. We need it to do homework. We need it to study. We use it in our social lives. We use it for entertainment. But there's one alarming study already that demonstrated that if we account just for TV type of screen time and entertainment, we see that children that have more than 2 hours of TV screen time already have an increase by up to 43% of developing obesity. Two hours a day of just kind of that entertainment type of screen time, the TV time, the games, and we notice that there's an increase in by 43% of obesity. And it's probably not just the sedentary time, but also the media. There's ads in everything that we do. You can't click on anything without an ad that you have to watch first. So there's a lot of factors that may be keeping them from, going outside. But we do want to really think about screen time. We know it's a fact of life. We use it to our advantage, but we also want to know that it is contributing likely to some of the obesity that we're seeing.
And just like Dr. Han was saying about the nighttime and the TV time. So one of the things that my kids and I do when I get home from work is we cuddle on the couch and we'll watch, something that's appropriate, which for us is like home building shows. So we'll sit down and my kids are 6 and 8, but on the commercials, because everybody's always trying to sell you something, just a couple weeks ago, it was a commercial which was a sugary cereal and advocating for that to be dinner. And it was the first time I'd seen this commercial. And I thought to myself, it's 7 o'clock at night. I'm on the couch with my kids and they're targeting my child to eat sugar right before bedtime, which we know the last thing you should do before you go to bed is eat a sugary snack for good sleep. And so all of these things are happening in concert with everything else to set up for failure for our kids right now. So to talk about the age and BMI requirements, I'd like to start off with the current recommendations by the American Academy of Pediatrics. In 2023, the American Academy of Pediatrics published a set of guidelines for the treatment of children and adolescents with obesity. And in these guidelines, they recommended that our PCPs, our pediatricians, and other healthcare providers at the age of 13 refer those patients with severe obesity to a pediatric bariatric center. So I think that's very important because the American Academy of Pediatrics guides what we do for children, and they have now realized that this is something that we need to address and address now. The current recommendations for the BMI are a BMI of 35 with a comorbidity, or a BMI of 40 with no comorbidity. And comorbidities could be anything: polycystic ovarian syndrome, diabetes, hypertension, sleep apnea, all of these things that we're currently seeing in adolescents, and the list goes on and on.
So referencing the same, revolutionary, that's the first time the American Academy of Pediatrics has come out with clinical practice guidelines. They came out last year. And it's a 100-page document, and it addresses quite a bit. And it does address obesity treatment and management for ages 2 and up. And we would start with what they call intensive health behavioral lifestyle treatment. And that is very much a family affair. We have to think about nutrition. So we often get a registered dietitian involved. We think about fitness and physical activity. We think about the psychological aspects of obesity. And it is recommended that we begin there, evaluating obesity, evaluating for comorbidities, and then treating in a multidisciplinary fashion. And that they actually gave us a guideline of what recommended time frame that would be. That's 26 hours of face-to-face contact. Most effective was actually above 50 hours of face-to-face contact, and over a period of 3 to 12 months. So that's how we would manage starting at 2 and up. We have some more tools in our toolbox as our children get older. They have recommended for ages 8 to 11, if they have obesity and comorbidities, we can consider pharmacotherapy for those children. And then for 12 and up, even for obesity without comorbidities, they recommend adding the pharmacotherapy with the treatment for obesity. We classify obesity in 1, 2, and 3. And for kids, we do BMI and percentage of BMI compared to the peers. So adults is straight BMI. So BMI for obesity for kids is 30 and above. And then 30 to 34.9 is class 1 obesity. Class 2 obesity is a BMI of 35 to basically 39.9. And then class 3 obesity is a BMI of 40 and above. So we take those numbers, but we also take into account how they compare to their peers in growth. And so class 1 obesity is either the BMI of 30 or above, or a BMI that's greater or equal to 95% of your peers. And this is interesting because sometimes when you look and calculate the numbers, that BMI might be 28, but it is greater than 95% of your peers, and now you are considered class 1 obese. On another side note, there is an ethnic variation. So the Asian population, where a BMI traditionally is 30 to be considered overweight or obese, obese, that's a different diagnosis from overweight, correlates. So in the Caucasian population, a BMI of 30 would translate for a person of Asian descent to a BMI of 27 would already be considered obese. So those are the classes that we use for pediatrics, though, is class 1, 2, and 3, or percentage of your BMI compared to peers of your same age and sex.
And when Dr. Han was talking about the best practice guidelines for kids, and that starts at 2. So previously I did research that showed that kids start with overweight and obesity at the age of 2. So what does that really mean? It means that started before then. And kids don't start getting on regular food until after 6 months to a year. And so we're really giving them these bad eating we're really giving them these bad eating habits a lot sooner than people would think. Because if you're already overweight and obese by the age of 2, then something had to lead up to that. And so that's why they're advocating for such intense therapy at that age and older if we're already seeing that.
And I'm going to piggyback onto that. So where does this even start? We can backtrack a little bit more, and even maternal health care and pregnancy we know can contribute to childhood obesity. So these clinical guidelines that the AAP came out with last year address basically treatment of obesity for 2 and up. And their goal in the next few years is to roll out obesity prevention and then discussion even for treatment for age under 2. So that's what's coming down the pipeline. The consensus is clear by BMI and comorbidities of when we should do bariatric surgery. However, the data that came from the AAP is based on 13 and up because that's all they have the data for. However, the American Board of Metabolic and Bariatric Surgery goes according to the World Health Organization and their definition of puberty. So that brings the age down to 10.
Yes. And previously, the AAP, or the American Academy of Pediatrics, has stated there shouldn't be restrictions based on age. And so although we put out there, and they have put out there in their best practice guidelines 13, because that is the data that they have, they also recognize that there's not data for less than that, but there are kids that have a BMI of 35 and 40 who are less than 13. So if you have a child that comes to you that's already that at 10, are you going to let them get to a BMI of 40, 50, 60 by the time that you say that they should have surgery? And so there are, and within our group of pediatric bariatric surgeons, we are definitely operating on children that are younger than that, because that's what happens. The evolution is they continue to gain the weight. So, and then if you let them continue to gain the weight, what do they have? A worse outcome after any treatment. And so I think it's really important to say that age limit is what is in the best practice, because all of those best practice is based on data, but some things we don't have data for yet.
Interesting that we have long-term data on surgery. We do not have long-term data on pharmacotherapy. Most of our effective pharmacotherapy tools for children were FDA approved in 2020 and 2022. But hands down right now, bariatric surgery has an average, and the sleeve is what we'll primarily be doing. And I've seen on the studies, and we have 8-year data published on that, and it's a decrease in BMI by 26% on average is what we're seeing. When we look at our pharmacotherapy, two of the major players that are more effective, one of them is going to be our GLP-1 agonist, semaglutide, and that currently we see a decrease in BMI of 15 to 17%. Coming right behind that is a combination medication approved for 12 and up, and that's phentermine with topiramate, and we have a BMI decrease of about 10%. So we've got 26%, 15 to 17%, and we have 10%. So right now, the clear winner on that is going to be bariatric surgery.
And to just piggyback on that, we did have, it was 2 years ago, we had 8-year data, and now we have 10-year data. So
hot off the press.
Yes, hot off the press, which is amazing. And so that's being presented at conferences all over the country, that we now have 10-year data that says that bariatric surgery is safe, it's effective, and we have long-term data in kids, not just in adults, but in children, 10-year data, and that it can even be up to 30% BMI reduction. And that is now the average, is up to 30% BMI reduction, which is 26 to 30. It doesn't seem like a lot, but any kid that we can reach that can have a successful outcome is amazing.
That's a great question, because it's going to be a team approach for sure. So first, oftentimes we actually probably should ask permission. Do we have permission to talk about your child's weight? So sometimes they're ready for that talk, sometimes they're not. We do bring it up at every visit we discuss. For all of our pediatric visits, our well visits, we do discuss growth and development. So we do want to ask maybe permission to hone in on a child's growth. And we often want to use terms such as, our goal is to reach a healthy weight. We want to make your child strong. So we definitely want to use non-biased language. So that's important to note, because obesity is a disease. It's not a personality trait, it's a disease. So we also want to make sure they feel safe talking about their weight, because we don't know what's happened at home, what's happened at school. It can be a very sensitive subject, and we need to be compassionate about that. We also don't want to play the blame game. Like we mentioned before, we talk about a lot of this is not in that child's control. This is what their genetics have dictated for them up to a point. And so we want to let them know that it's something that we can work together with for them to have them lead happier, healthier lives.
And I would say it is a very difficult conversation to have. And that's why the guidelines were published in 2023, because they realized we're not having those conversations. And so previously I had an adolescent bariatric program. I also had a childhood weight loss program where I was prior to being at Cook Children's. And I can't tell you the countless number of kids that would come to see me, and the parents would have no idea why they were there. I'd say, so what can I do for you today? And they would say, well, we don't really know why we're here. And I would say, well, this is a weight loss clinic. And they would say, but we're not overweight. And I said, well, you kind of have to be, because you have to be at the 99th percentile for age and weight to even get in this clinic. And so it's really, you have to meet them where they're at. You have to have in a very compassionate way, so not doing the blame game. But really it starts off with, how do you feel about your weight? What are things that you can do and can't do with your weight? And so it really starts meeting them at where they're at.
As a primary care provider, you do not need to do any legwork for the referral. That's what we're here for. Just identify the patients that may benefit from obesity management and services and refer them to our multidisciplinary clinic, and we will do the workup. That workup often entails evaluating for obesity and any comorbidities that may involve, it definitely will involve, ordering labs. And we also want to look at the big picture and at each patient holistically. And they will also be seen by a psychiatrist, a registered dietitian. They'll meet with the team. We have physician assistants, we have surgeons, we have our obesity medicine specialists. We also will be addressing any comorbidities of obesity, which may involve meeting with a nephrologist, a cardiologist, a gastroenterologist, an endocrinologist, a sleep medicine specialist. So we will take care of the entire workup from start to finish, and that finish is probably along the lines of potentially for a thorough workup and evaluation up to 6 months.
So we're big on communicating with the patient's PCP. So if they are a cook PCP, then they will get the Epic inbox of all the notes after we have seen the child. If they are a non-cook provider, what will happen is they get the faxes from that. And of course, Dr. Han and I are always available, and we love it when PCPs are involved in the care of their patient. So they can call us at any time, text, email, we're always available.
It will. It will include all aspects of it, medical management of the obesity, and if needed, medical management of the comorbidities of the obesity. So to start off, we do labs evaluating their obesity and their metabolism and looking for any other organs that might be involved. So that usually involves a complete blood cell count, a comprehensive metabolic profile, which has liver and kidney information that we get from there. We will also do a urine screening. We'll look for diabetes risk factors, hemoglobin A1C, our fasting glucose is part of our comprehensive metabolic profile. There are some cases that we will also look for known genetic causes of obesity, and that can be done in the office, and we do that on a cheek swab. So some of our candidates will also need some genetic testing prior to entering the protocol. So that's often where we start. Sometimes there's imaging involved. And then with regards to pre-surgery, we're looking a lot with regards to nutrition by then. We do follow-up labs afterwards. 1 to 2 months afterwards, 6 months, you may have to correct me if I'm wrong, and then annually. And a lot of that focuses on nutrition afterwards. We're looking at electrolytes, we're looking at calcium, we're looking at vitamin deficiencies. So those are the standard labs.
Postoperatively, we see the patients at 2 weeks, 1 month, 3 months, 6 months, and then annually after that. And we follow patients for 4 years. And so if the patient has any problem, when they come back to our visit, we may see if they start to regain some weight. We may see that they're losing too much weight. We are able to put them right back in that program. They have all the services that they had before, and will continue to have those for 4 years. A lot of times when people ask me what the recovery is, they're imagining these big surgeries where they're going to have an incision from here to here, back how we did it 20 years ago. It's not 20 years ago. All of our incisions have gotten very small, no matter what surgery we're doing, honestly, these days. And so their recovery is typically they're home the next day. 80% of the patients go home the next morning. In addition to that, the majority of kids are back within school within a week. Yes, so they're not missing a lot of school, so you don't have to wait for a certain time of year or this kind of thing so that they can get their health taken care of. We now have wonderful preoperative and postoperative protocols for anesthesia and for general surgery that minimize narcotic pain medicine and also minimize nausea, which was one of the big things that used to be a problem. Also, over 90% of the bariatric surgical procedure that is done in kids is a laparoscopic sleeve gastrectomy. And that only has an early complication rate of 2.6%. So what does that mean? 97% of patients are going to do great afterwards. But I really want to stress the most important part of this is the work that is done the 6 months before, because that sets the stage for a successful surgery and sets the stage for a successful outcome. So I think from what I see is that people still feel that this is a willpower thing. So we're not doing enough. He doesn't want it enough. He needs to exercise more. He needs to eat less. They need to do all these things, and they're constantly pushing. But 40, what did we say? Up to 70% of this is genetics. Just like I said, you cannot outrun genetics. And so I think are some real unrealistic expectations about what people can do to their body for change. And I think because as a society, that's what we tell everybody. Like, oh, they're just not exercising enough. They're just not eating enough fruits and vegetables. And that's not necessarily the case. And so I think that's the first hump to get over, is that people feel, even within themselves, that they should be able to do it on their own. But if that was the case, look at the industry. It is a billion-dollar industry, weight loss and Weight Watchers, all the apps that you have on your phone to try to count your calories, the gyms, the memberships, billions of dollars. So if it was really that great, if the solution was that simple, would we have that? And the answer is no.
I'd have to agree. I think the biggest thing that we're fighting right now is the definition of obesity. Obesity is a chronic disease. It is a disease. It's not because you can't control your eating. It's not because you don't exercise enough. It is none of those things. It's predominantly genetic. There's a 30% environmental factor that we can vary and work on that. But in general, we have to recognize that obesity is a disease. It is a genetic disease, like allergies. Not everybody has allergies, but a lot of people in the same family have allergies. Allergies, asthma, if we can just reframe our mindset, and I think that will help with people overcoming this idea that it's more of a lifestyle disease. So why would I need to take medicine? Why do I need surgery? I just need to change what I'm doing.
And that takes us back to what we had said about we treat all diseases. We treat hypertension. We treat diabetes. It's very difficult for people to get over this mental hump of obesity as a disease, but that is exactly what it is. As we previously said, the CDC says that this is the leading cause of death, preventable death in the United States. There are a plethora of things that happen after surgery. Like I said before, most important is the 6 months leading up to surgery. But after surgery, they have diets that they need to stick to. So that means over the first 2 months, they're going to go from a clear liquid diet to a regular diet. After surgery, what we typically see is an average weight loss of 1 pound per day for the first 30 days. And what we typically see at a year is a 30% reduction in BMI. So if we keep in mind, if somebody starts at a BMI of 40, at 1 year, they are typically at a BMI of 28. And that is life-changing for children. So you have to remember, these are still adolescents. They still need to be with their peers. They still need to be interacting outside. And when they're at a BMI of 40, they're not doing those things. And that's pivotal for their development and their neurologic development at this age. And it's also just wondrous to see when it actually happens, to see them open up and engaging. So the only time that we use medications postoperatively is at their 3-month visit. If they are not on track for what we know that they need to be at for successful continued weight loss, at that time we can add medication. It's not something that is the norm. It's not the majority of patients, but we have that in our back pocket to have them be successful. And we follow them very closely after surgery. So as we said, that's 2 weeks, 1 month, 3 months, 6 months, and then a year. If at any of that time we see that we need to add medication, and Dr. Hahn starts to prescribe that medication, of course she's going to see them more than 6 months from then, because we want to make sure that we're having an adequate effect. So we talked about how it's 1 pound per day for the first 30 days. They need to continue to stay just on a growth chart where we see kids and you want to see them with a normal line going like this. We want to see our kids with a normal line going like this. So let's say that they start to lose weight. They lose 30 pounds in the first month, which is excellent. and they only lose 2 pounds after that the second month. So that means the line is going to start to plateau out like that. We don't want to see that. We need to have continued linear downward growth, downward loss, so that they reach their ultimate end goal of that somewhere between 25 and 30% average BMI loss. So the typical lifespan of a child that suffers from obesity is 10 to 20 years less than their peers. That's why this is an epidemic. 10 to 20 years off of somebody's life, off of a child's life, you know? And so it was interesting. This week, I went and met with a medical director at one of the local EDs. And the other thing about this is that they're seeing conditions that we normally see in 40 to 60-year-olds. So when I was talking to this medical director at the ED, he said he had a patient that came in their 20s that suffered from severe obesity and had a heart attack. A heart attack in the 20s. And this is what it is. If you start at 13, where do you have to go but up? And so we're really trying to get to kids before they're in their prime and they're trying to live their lives and trying to live a healthy life. You can't live a healthy life having a heart attack in your 20s. So Dr. Han talked about this a lot, and so it is a 6-month program. And so they're meeting with all of the specialists. So they're meeting with the dietitian, they're meeting with our obesity specialist, they meet with myself as the surgeon. We have advanced practice providers that they also meet with, and they do all of that for 6 months in addition to the psychological review. Okay, if they need something, if we discover that they have insulin resistance, if we discover that their EKG is abnormal, then we have all the other subspecialists that we can refer to at that time. I think it's also important to set realistic expectations. Not everybody that comes into the program is going to complete the program. And that's no matter what we do, right? We just talked about how hypertension is a disease, how diabetes is a disease. Some people take their insulin, some people don't. Some horses you can lead to water, some won't drink. And so we do the best that we can for each child. At the end of the day, they have to pass their psychological evaluation. They're not going to be successful if they can't do that. At the end of the day, we have a bariatric committee, and that's with the dietitian. That's with our obesity medicine specialist. That's with me as the surgeon. We review the child's complete record. If they've missed appointments, no showing appointments, not doing what the dietitian has asked them to do. Sometimes we give a series of quizzes to make sure they understand what is a carb, what is a vegetable, what is a fruit, how many ounces of this are you going to have, how many ounces of water am I supposed to have after surgery. If they can't answer these questions, they will not be successful. And we want to make sure that we set everybody that's going to make it through the program up for success.
To providers, to families, please don't hesitate to make a referral to us. As we said, not everybody's going to be a candidate, but we would certainly like to share information, share opportunities, and work with our families and our providers to make a dent in this obesity epidemic. It's our pleasure, and please don't hesitate to reach out to myself or Dr. Bowen-Jallow at any time for any of your needs.
Absolutely. And, this is really a passion for Dr. Han and I. And so I think that shows in our work, and it will also show in how we treat your children.